Hello, everyone, and welcome to our second module on cranial nerves. Okay, let's start by talking about cranial nerve number 8, which is the vestibulocochlear nerve. This is a purely sensory cranial nerve. It's responsible for sensory functions like equilibrium and balance, related to the vestibular system, and also hearing. And it splits into two portions. One is the vestibular nerve, and one is the cochlear nerve. The vestibular nerve controls vestibular functions, which I talk about in the video on the vestibular system. So this is things like compensatory eye movements, keeping the eyes aligned, and also balance. And so when you get lesions involving the vestibular nerve portion of cranial nerve 8, symptoms that occur are things like vertigo, nystagmus, disequilibrium, and I talk about all these things in the video on the vestibular system. The cochlear nerve is sensory for hearing, and so lesions here result in hearing loss and also sometimes tinnitus, which means ringing in the ear. So if you look at this drawing on the slide here, this is a depiction of the vestibulocochlear nerve. So it's sensory to the vestibular system, shown here, and also the inner ear and the cochlea, shown here. And then all those sensory nerve fibers enter the skull through this structure indicated here, the internal auditory meatus. It's part of the temporal bone. They then enter the brainstem at a region called the cerebellopontine angle. This is the junction between the pons and the medulla in the brainstem and also the cerebellum. And this is important to know about because this is a location where tumors called acoustic neuromas, they're also known as vestibular schwannomas, often develop. And so when they grow in this region right here, they can disrupt the function of the vestibulocochlear nerve. Once this nerve and its fibers reach the brainstem, there are multiple brainstem nuclei. For example, there are 2 cochlear nuclei, 4 vestibular nuclei. It's not important to know the names and locations of all these separate nuclei. The only thing you really need to know is that they're all located near the medulla pons junction, sort of in the upper medulla right at the base of the pons. There are a couple of tests that are sometimes done clinically to assess cranial nerve number 8, so let's talk about those now. The first one is the oculocephalic reflex, also known as the doll's eyes test. This is really an assessment of overall brainstem function, but it includes an assessment of cranial nerve number 8. This test is done on an unconscious patient, and the idea is to use this test to see if the brainstem is intact. The way you do this test on an unconscious patient is, first of all, you hold the eyelids open like what's shown here in this panel, and then you rotate the head side to side while the eyelids are held open. When you turn the head to one side, the eyes should rotate in the opposite direction so that they stay focused on the same position in space. And then when you rotate the head back, the eyes should go back to midline. And you can rotate the head in the other direction and the same thing will happen. So the normal response indicating that the oculocephalic reflex is present is that the eyes move in the opposite direction as head movement. And in order for this reflex to be present, you need intact cranial nerves 3, 4, 6, and also 8. And so this is one way of assessing cranial nerve number 8. On the other hand, if the oculocephalic reflex is absent, then the eyes remain fixed. They move with the head. They don't move back to midline like what you see here in this picture as you rotate the head. And this indicates severe brainstem dysfunction or damage, including problems with cranial nerve number 8. Another test that's sometimes done in unconscious patients to assess cranial nerve number 8 is called caloric testing. This test uses warm or cold water injected into the ear to assess the vestibulo-ocular reflex, meaning the reflex between the eyes and the vestibular nerve. This is done in an unconscious patient, and the way you do it is you inject either cold or warm water into an ear. Let's talk about what happens first when you inject cold water into an ear. What the cold water is going to do is it's going to numb up cranial nerve number 8 and disrupt its function. And the brain is going to interpret this as a mimic of head rotation away from the cold water side where you're injecting water into the ear. So what the eyes are going to do is move slowly towards the cold water. This is mediated by cranial nerve number 8. When the body detects this, there's going to be rapid correction back to the opposite side. This is mediated via the cortex. So a normal response is you inject cold water into one ear, there's slow movement of the eyes toward the ear you inject cold water into, and then a fast movement away. This is the correction. And so if cranial nerve number 8 is not working, there will be no slow movement towards the cold water. And if there's a problem with the cortex, there will be slow movement towards the cold water, but no fast correction away. You can also perform caloric testing by injecting warm water into the ear of an unconscious patient. And when you do this, the warm water will stimulate cranial nerve 8 function on that side. Essentially, this creates a relative opposite side cranial nerve 8 lesion. Basically, it does the same thing as injecting cold water into the opposite ear. So when you inject the warm water into one side, the eyes will move slowly away from the side with the warm water. This is done by cranial nerve 8. And then there will be a rapid correction back towards the warm water side mediated through the cortex. So the normal response to warm water injection in one ear is slow movement away from the warm water side and then fast back toward the warm water side. If cranial nerve number 8 is not working on the side where you inject warm water, then there will be no slow movement away from that side. And if the cortex is not working, then you will see slow movement away, but no fast correction back toward the warm water side. And so there's a mnemonic that medical students have used for years and years to remember how caloric testing works. That mnemonic is cold opposite, warm same. It goes by the mnemonic COWS. And basically it's named for the side of fast correction. When you inject cold water, you get a fast correction toward the opposite side. When you inject warm water, you get a fast correction toward the same side. Okay, moving on. Next, let's talk about cranial nerve number 9, the glossopharyngeal nerve. This nerve has motor, sensory, and autonomic nervous system functions. So let's talk about each of these functions one at a time. So its motor functions involve one muscle, the stylopharyngeus. This is a muscle that elevates the pharynx. It's important for swallowing. It has a couple of different sensory functions. First of all, it provides taste and other sensation to the posterior third of the tongue. It also innervates the carotid body and sinus, where you find chemoreceptors and baroreceptors that help regulate things like blood pressure and respiratory rate. And then it also provides general sensory information to the middle ear. And then finally, in terms of autonomic function, it is responsible for salivation via the parotid gland, so it can stimulate the production of saliva. This nerve has multiple nuclei, all found in the medulla. Some of them have strange names like the nucleus ambiguus and the nucleus solitarius. These are shared nuclei with other cranial nerves, and I talk about them later in this video. Down here at the bottom, I've written the names of the different nuclei right here and their function. I think it's pretty low yield to memorize all this, but I'm showing you the names just so you've heard them at least once. And then the nerves of the glossopharyngeal nerve have to go in and out through the skull, just like all the cranial nerves, and the opening that they use is the jugular foramen. That's depicted here in this image right here. And you can see the nerve fibers going to structures like the parotid gland and structures like the tongue and the pharynx. Because the glossopharyngeal nerve has so many different functions, there are a number of different clinical features that you can see when there's a lesion to this nerve, and I've summarized them all in this table here. So first of all, you lose the gag reflex on one side when there's a lesion of the glossopharyngeal nerve. So if you touch the back of the throat on the affected side, there won't be a gag response. This is because the sensation from the back of the throat, the afferent limb of the gag reflex, is mediated through this nerve. There can also be problems swallowing. That's dysphagia. That's from loss of that stylopharyngeus muscle function. Taste is lost in the posterior third of the tongue because of those special sensory fibers. In general, you can get reduced sensation in the pharynx. That's from loss of sensation to the oropharynx. There can also be decreased salivation from the parotid gland because those autonomic parasympathetic nervous fibers are disrupted. And finally, some patients develop otalgia, which is ear pain, and this is because of irritation of the nerve that provides sensory information to the middle ear area. Okay, our next cranial nerve is cranial nerve number 10, the vagus nerve. It has both motor and sensory functions. Let's talk about the motor functions first. So the vagus nerve innervates pharyngeal muscles that you need for swallowing and also for gagging and the gag reflex. So we just talked about how sensation for the gag reflex comes from cranial nerve number 9, but the muscular gag response of that reflex is mediated through cranial nerve number 10. The vagus nerve also innervates laryngeal muscles you need for speech. These are innervated by a branch of the vagus nerve called the recurrent laryngeal nerve, which I'll talk more about in a second. And then the vagus nerve innervates soft palate muscles that are at the top of the throat that help to keep the uvula midline. In terms of sensory functions, there are some taste functions mediated by the vagus nerve. You may think of most of our taste being mediated by the tongue, and it is, but you can also have some taste sensation from the epiglottis and the base of the tongue, and that taste sensation is via the vagus nerve. And then the vagus nerve is also responsible for visceral sensation of viscera, meaning organs that you find in the thorax and in the abdomen. Those are innervated by this nerve, and when there's dysfunction of these organs, that pain and that irritation sensation is mediated through the vagus nerve. The vagus nerve also has important autonomic nervous system functions. First of all, it innervates chemo and baroreceptors you find in the aortic arch. These help to maintain blood pressure. I talk about these in videos in the cardiology section. The vagus nerve also sends parasympathetic nerve fibers to the heart that can slow the heart rate via cardiac branches of the vagus nerve. Parasympathetic fibers of this nerve can also constrict the bronchi, and they can also stimulate peristalsis and secretions in the GI tract. And I talk about this nerve a lot in videos in the GI section for this region. The vagus nerve has multiple nuclei in the medulla. They all go by these strange names like the nucleus ambiguus, the nucleus solitarius, and others. These are shared nuclei with multiple cranial nerves, and I'll talk a little bit about them later in this video. And then finally, the fibers of the vagus nerve exit the skull through the jugular foramen. This is the same exit that's used by cranial nerves 9 and also cranial nerve 11. Just like with cranial nerve number 9, because the vagus nerve has so many different functions, there is a wide range of clinical features you can see with a lesion. I've listed the major clinical features on this table on this slide. So first of all, vagus nerve damage can lead to dysphagia. This is because of paralysis of those pharyngeal muscles it innervates. It can also lead to difficulty speaking, that's dysphonia or hoarseness of the voice, and this is from laryngeal muscle weakness related to the recurrent laryngeal nerve, which we'll talk about shortly. At the back of the throat, the uvula can deviate away from the side of the lesion if there's a vagus nerve problem. This is because of paralysis of the soft palate. So the side that remains intact will pull the uvula towards it, and that's why the uvula will deviate away from the side of a vagus nerve lesion if it's on the left or right. You lose the gag reflex with a vagus nerve lesion. This is the efferent limb, meaning the motor limb of the gag reflex. As we've already talked about, cranial nerve number 9 supplies the afferent or sensory limb of the gag reflex, but that gag response to irritation in the back of the throat is via the vagus nerve. And then finally, you can have autonomic dysfunction if there's damage to the vagus nerve. So first of all, the heart rate will speed up. Basically, parasympathetic fibers via the vagus are always suppressing the heart rate to keep it normal. So if you cut the vagus nerve, the heart rate will rise and there will be tachycardia. You also lose parasympathetic innervation to the GI tract, so this can lead to constipation and impaired GI motility in general. Okay, so I've mentioned this nerve a few times, but let's talk about it in a little bit more detail now. So the recurrent laryngeal nerve is a branch of the vagus nerve that ascends towards the larynx and innervates the muscles you need for speech. And it ascends in a region between the trachea and esophagus called the tracheo-esophageal groove. So if you look at this drawing on the slide here, these are the two vagus nerves coming down from the brainstem. The left vagus nerve is going to give off this recurrent laryngeal branch, which loops around the aortic arch and goes up to the larynx to innervate the muscles of the larynx. The right vagus nerve is going to give off a recurrent laryngeal branch as well. However, it loops around the subclavian artery. And this is on the right side of the body over here. This is on the left side over here where the recurrent laryngeal nerve goes around the aortic arch. This nerve is sometimes damaged in thyroid surgery, and when this happens, that can lead to hoarseness of the voice. You can also have this nerve get compressed in certain special circumstances, and that also can lead to hoarseness of the voice. The two classic circumstances where this can happen are in patients who have mitral stenosis with an enormous left atrium or in patients having an aortic dissection. Once again, if we look at this picture here, the left recurrent laryngeal nerve goes around the aortic arch. So if there's a dissection and the aorta expands rapidly, that can compress this nerve and cause hoarseness of the voice in a patient having an aortic dissection. And then the left atrium sits down here. So if it gets enormous from mitral stenosis, which doesn't happen much anymore in the modern era, but it used to happen a lot, it can compress this nerve as well, and that can lead to hoarseness of the voice in a patient with mitral stenosis. Let's talk briefly about vasovagal syncope, which is the most common cause of syncope or fainting. It's called vasovagal because it's related to stimulation of the vagus nerve that increases parasympathetic outflow via the nerve to the heart. And so when the parasympathetic outflow via the vagus nerve to the heart goes up, the heart rate will fall, the cardiac output will fall, and that can lower the blood pressure. Potentially, this can cause a person to faint. There are many triggers that can cause this increased parasympathetic outflow. Some of the common ones I've listed here, things like hot weather, prolonged standing, pain, the sight of blood. We don't know why some people get triggered by these things and faint, whereas other people do not. But when someone does have a trigger by one of these things and they faint, that's called vasovagal syncope. Okay, our next cranial nerve is cranial nerve number 11, the spinal accessory nerve. This is a purely motor nerve that innervates two muscles related to the shoulder, the sternocleidomastoid muscle and the trapezius muscle. You need these muscles to turn your head to one side and to shrug the shoulders. So if there's a lesion of this nerve, what patients will complain of is difficulty turning their head towards the normal side. That's the way this nerve and these muscles work. Patients will also develop shoulder droop on the abnormal side, meaning the side that has the lesion will have the shoulder lower than the other side. That's shoulder droop. This is a funny cranial nerve because its nuclei are not in the brainstem or higher. They're actually in the upper spinal cord. The fibers arise from the C1 to C5 region of the spinal cord, and then they all come together and they enter the skull through the foramen magnum, which is the same hole that the spinal cord goes through. Then they exit the skull at the jugular foramen along with cranial nerves 9 and 10. So this is a funny cranial nerve in that it arises from the spinal cord, and it's the only cranial nerve that enters and also exits the skull. And then our final cranial nerve is number 12, the hypoglossal nerve. This is a purely motor nerve that is responsible for the muscles that control tongue movement. And so if there is a lesion of this nerve on one side of the body, the tongue will deviate toward the abnormal side. Basically, the opposite side, which is still working, will push the tongue away unopposed, and therefore you'll get deviation of the tongue towards the abnormal side. It has nuclei that are found in the medulla of the brainstem, and it exits the skull through an opening called the hypoglossal canal. Okay, so that's it for the 12 cranial nerves. What I'm going to do now for the rest of this video is highlight a couple of special features of the cranial nerves that you should be familiar with. And I'll start by talking about shared nuclei. So many cranial nerves share brainstem nuclei, and by this I mean that there are common hubs in the brainstem that give rise to motor and sensory signals from multiple different cranial nerves. There are a number of these shared nuclei, but two that you should be familiar with are the nucleus ambiguus and the nucleus solitarius. So the nucleus ambiguus gives rise to motor fibers from the medulla, and these motor fibers supply structures innervated by cranial nerves 9, 10, and 11. So you will read that all three of these cranial nerves arise from the nucleus ambiguus, and that's because it's a shared nuclei. The nucleus solitarius is a shared nuclei for sensory fibers. It's also found in the medulla. So sensory fibers from cranial nerves 7, 9, and 10 all arise from the nucleus solitarius. And so when you read that these cranial nerves arise from the nucleus solitarius, they're talking about one of these shared nuclei. Let's review some of the cranial nerve reflexes. I've touched upon these when we talk about individual nerves, but I'll summarize them here for you. So the corneal and lacrimation reflexes are a response to corneal irritation. This is usually tested by taking a cotton swab and tapping the patient's cornea. The response that you will see in a normal reflex is that the patient will blink. This requires cranial nerve 5, the V1 branch, to sense this, and cranial nerve 7 to cause the blinking of both eyes. You will also see tears in response to touching the cornea. Once again, the touching is sensed by the V1 branch of cranial nerve 5, and cranial nerve 7 is important for generating the tears. And then just sort of an aside here, but if you have damage to cranial nerve 5 and you don't have the V1 sensing branch of this reflex, you can still generate emotional tears because they're generated by higher structures in the cortex. As long as cranial nerve 7 is intact to stimulate tear production, emotional tears are still possible with damage to cranial nerve 5. And then the gag reflex is performed by using a tongue depressor or swab to tap the posterior pharynx on the left and right side. The normal response is when you touch the pharynx contracts and the patient gags. And in order for this reflex to be intact, you need cranial nerve number 9 to sense the touch in the back of the pharynx and cranial nerve number 10 for the gag response. To test the jaw jerk reflex, you place a finger on the patient's chin and then you tap the finger, usually with a reflex hammer. And if this reflex is intact, the jaw will jerk upwards. This is a picture of this reflex being assessed on the slide here. This is basically a test of the trigeminal nerve, cranial nerve number 5. You need the V3 branch of cranial nerve number 5 to sense the tap and also for the jaw to jerk. And then the pupillary light reflex involves shining a light into one pupil, and then both pupils should constrict if the reflex is intact. You need cranial nerve number 2, the optic nerve, to sense the light, and then you need cranial nerve number 3, the oculomotor nerve, for the pupils to constrict. You can use speech to test certain cranial nerves. Let's talk about that now. So if you ask a patient to say guh, 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 in order to make this sound, you have to raise your palate, so you need cranial nerve number 10 to be intact. Then there are sounds that you need the lips for, like ba, ba, ba. You have to move your lips to make this sound. Try it now if you want to see how this works. So you need cranial nerve number 7 in order for the lips to move normally. And then finally, la, la, la involves moving the tongue, and so this depends on cranial nerve number 12. So that's a nice segue into talking about the tongue because it's innervated by multiple different cranial nerves, so let's go through that carefully now. So motor control of the tongue, moving the tongue, this is mostly related to the hypoglossal nerve, cranial nerve number 12. And as we've already discussed, a lesion of cranial nerve number 12 will cause the tongue to deviate toward the affected side. There's one exception to this, and that is the palato-glossalus muscle. This is one muscle of the tongue, and it's controlled by cranial nerve number 10. So you can see some motor weakness of the tongue with a vagus nerve lesion. General sensory innervation of the tongue refers to sensation for everything outside of taste. So sensing things like pain and pressure and temperature and touch around the tongue. This is mediated by different nerves depending on which part of the tongue you're talking about. The anterior or front 2/3 of the tongue has general sensory innervation by the mandibular branch of cranial nerve number 5, that's V3. The posterior third is via the glossopharyngeal nerve, cranial nerve number 9. And then the root of the tongue and a little bit in the back of the mouth, that has general sensory information from cranial nerve number 10. Taste, however, is different from general sensation. Taste for the tongue is innervated by cranial nerve number 7 for the anterior 2/3 and the glossopharyngeal nerve, cranial nerve number 9, for the posterior third. Then, as we talked about earlier, you can also have some taste from the root of the tongue and the larynx and the upper esophagus, and taste here is mediated by cranial nerve number 10. And so if you look at this drawing of the tongue right here, this region right here where the tongue switches to being very bumpy, that's called the terminal sulcus. And this is what separates the anterior 2/3 of the tongue from the posterior 2/3 of the tongue. And this drawing here actually summarizes the different cranial nerves that innervate taste to different parts of the tongue. So you've got the vagus nerve, cranial nerve number 10, doing the root, the back of the tongue right here. Glossopharyngeal nerve is doing the posterior third, and then the facial nerve, cranial nerve number 7, does the anterior 2/3. And then the last topic for this video I'll talk about are cranial nerve pathways. So cranial nerves need to get in and out of the skull in order to provide motor innervation to muscles or to bring sensory information into the brain. And so it does this through a number of holes, and let's talk about where they're found now. So the base of the skull has 3 depressions called cranial fossa. They're shown here in this top image. There's an anterior fossa right here, a middle cranial fossa here, and a posterior cranial fossa here. And each of these 3 fossa has holes for the cranial nerves. The anterior cranial fossa only has one hole that is used by a cranial nerve. That's the cribriform plate, and this is how cranial nerve number 1, the olfactory nerve, sends signals in and out of the skull. The middle cranial fossa, which is a much bigger fossa, has holes for cranial nerves 2 through 6. I've listed what those various holes are here. I mentioned all of these openings of the skull, specifically when I talked about these cranial nerves. And then finally, the posterior cranial fossa is where you find the entry and exit holes for cranial nerves 7 through 12. That includes all these cranial nerves here. I mentioned these openings in the skull when I talked about the individual nerves. And remember that cranial nerve number 11 is that funny nerve. It comes in through the foramen magnum, but then goes out of the skull again through the jugular foramen. And that concludes our second video on cranial nerves.